Our first speaker is Dr. Adam Young. Dr. Young is an anesthesiologist and pain management specialist with Rush University Medical Center right here in Chicago. And I have to tell you, I never hesitate to refer patients to him because they always come back with a good report, even if he doesn't tell them exactly what they want to hear, which, we're pain patients, that happens a lot. They always have a good report. They say that, he was kind and compassionate and he took this time to explain their conditions or their options to them. And he may not know it, but he does now, that his nickname is Dr. Smiley. You're going to see why in a minute here. The medical conditions, some of the medical conditions that Dr. Young treats include arthritis, CRPS, facet joint pain, fibromyalgia, back pain, and migraines. The list goes on and on, but that's just a few that I chose to put here. He's a really great person too, in addition to being a good doctor, which to me as a patient is really important. I don't like to work with people that aren't, with doctors that aren't good people, as well as being good doctors. So it is my pleasure and my honor to welcome back Dr. Young. He's been a speaker for us before, and the 1 year that he was absent, people complained. They really like having him here. So please welcome Dr. Young.
Good morning, everybody. My name's Adam Young. I'm a pain doctor in Chicago at Rush. First off, just want to say thank you for having me back. I'm glad there wasn't a riot, I guess, in the year that I didn't show up, but thank you, Gracie. Speak louder. It's usually not a problem. Okay. So thank you very much for having me back. Today, I want to talk about pain treatment that I offer to my patients, certain patients, that I feel it can be of benefit to, and that treatment is spinal cord stimulation. Now, it's something probably, I'm guessing many of you have probably heard of or read about in the past, or a doctor may have brought it up to you along your path of treatment in dealing with your chronic pain syndromes. But today I want to go through it in a very simplistic, basic way so that you have a broader understanding of what it actually does. Now, one caveat, though, is nobody really understands exactly what it does, but I'll give you the idea about what we really think it does, okay? So, spinal cord stimulation. We know that the nervous system is composed of your brain and your spinal cord, and that's your central nervous system. And everything that comes off of the spinal cord are called your peripheral nerves. Now, as we take a closer look at nerves, this is kind of what they look like. You see this outer covering, and then inside of that, there's another bundle. And if you look even closer to that, there are even smaller bundles that are made up of these individual nerves. I don't know if anybody expected to get an anatomy lesson today, but this is essentially what nerves look like. So your sciatic nerve is going to be a large bundle, even larger, much more what we call these neurofibrils, all together composed of these individual neurons. Millions, billions of these in your body. Now, as we look even closer at a nerve cell, this is where things start to get really interesting. So if this is your cell wall, these things right around here, these are called ion channels. Now, these things are important, very important, because what they do is they allow passage of potassium and sodium in and out of your cells. This is how nerves can act like an electrical wire, sending electrical signals. Because if you check this is actually just a way to kind of represent the electrical energy that's stored in nerves. So your body goes to all this trouble of making sure there's a lot of potassium in the nerve and very little sodium in it. When your body wants to send a signal along that nerve, all of a sudden, potassium channels open up, potassium goes out, sodium channels open up, sodium goes in. And all of a sudden, what they call an action potential, or a nerve signal, is sent along that length of nerve. It's electricity. You can measure it with this equipment, high-tech equipment that can tell you it's electricity. Has anybody ever had an electrical shooting pain? Yeah. That is why. This is why it feels like an electrical shooting pain. It's because this is all your body's way of producing its own electricity. And so, you have problems with these sorts of nerves, you start to develop what we call neuropathic pain or nerve-related pain. It's a very different type of pain than pain you feel after certain types of surgery. It's pain that's slightly different when you have arthritis as your main pain generator. And there are a number of ways that we treat this. Common stuff we use medications. Medications like gabapentin, Lyrica. I'm sure everybody's heard of those. Antidepressants. Cymbalta is one that I use quite often. Topical medications, lidocaine, ketamine creams, these sorts of things. And then opioids or narcotics. I mean, that's truthfully not treating the problem, it's masking it, but it's a very common thing that I see patients that come to me, they're already taken. Other things that we do for nerve-related pain, try to figure out other ways to treat it, because the medications usually don't do much, but blunt pain, they'll definitely give you side effects. They'll make you foggy. Some of these will make you constipated. And they'll make you feel a whole bunch of other things you really don't want to feel. We tried nerve blocks to see if certain types of nerves that are involved, that we suspect are involved, will actually give you some relief. Sometimes it's just temporary, and sometimes it can be a longer result. We use TENS units sometimes, and that's a superficial application of electrical energy to try to stimulate some of the nerves in your skin to see if you might be able to get some relief that way. And so going to these TENS units, this is kind of one of the more rudimentary ways of using electricity to treat pain. And so you see that you have a current that's spread from one of these electrodes to another. So some people have multiple little sticky pads on themselves as they're using their TENS unit. And then you have these signals that are sent, and they change the way the small, tiny nerve endings in your skin will sense pain. So maybe there's less signals overall that are sent to the brain. Maybe those little nerves in the skin are just confused. Maybe it's that more endorphins are released, your body's natural, what they call feel-good hormones. But truthfully, TENS can be kind of hit or miss. There's not great evidence to say that it works, but on the other hand, it's not another pill you're popping. It's not something else you got to remember to take every day or you could go through withdrawal from. It's something that you can use when you need it, if you want it. But more sophisticated ways to use electricity to treat pain are something called spinal cord stimulation. So let's back up just a minute. Now, electricity to treat pain has been around for decades, maybe even more. The first reports are actually from old scrolls found in ancient Greece that say that Romans, Egyptians used to use electrogenic fish to treat headaches. That's right, electrogenic fish. There are certain fish, torpedo fish, they have these really cool bodies. They have electrogenic organs they can create. You've heard of electric eels, right? Well, yeah, they can create an electric current. So in 50 AD, Scribonius Largus, this is one of the first reported reports, was one of these physicians that was using electricity to treat pain. And one of the things they used to treat was headaches. Can you imagine going to a doctor and saying, you know, I'm having these terrible migraine headaches. And the doctor says, just put a fish on it. No, but the idea is there that this actually is something that worked. And it largely was ignored for a while until the 60s. And so this is when electrical stimulation first kind of came back to the field of medicine. And this is where there was a patient with really awful, intractable, cancer-related pain that was invading his spine and his nerves. There was these two doctors, neurosurgeons, Wall and Sweet, that ended up implanting this device right here. It was pretty rudimentary. This thing actually came out through the skin. This thing was sewn directly to that sac of fluid that holds the spinal cord. And this little battery sat over top of this thing, and the guy did great. It was impressive. Nobody had ever seen anything like this before. But the problem is you can't live like that. That's not going to work. You can't live with a wire coming out of your body sewn directly to the dural sac. That's not going to work. All right. Now, in addition to an anatomy lesson, I'm going to give you a little physics lesson today too, okay? So this is how an electromagnetic field is generated. So this is one of the reasons we're going to start to get into how we think spinal cord stimulation actually works. And this is just something you need to kind of be able to wrap your head around, is that when you talk about electrical energy, we talk about voltage, we talk about current. When you have electricity flowing in one direction along a wire, the interesting part of this is that you generate a magnetic field. The magnetic field is perpendicular to that current. So as you see in this little depiction here, as you flow from positive to negative here along this, you start to generate this magnetic field. It's obviously stronger in here, a little bit less as you go out. And we may come back to this at some point, but I just wanted to introduce that. This electrical energy here, this is how we kind of think it may work. We may find out 10 years from now that all this is completely wrong, but for now, this is what we have. Is that when you stimulate the spinal cord at certain levels, as long as those nerves that are coming from the areas you want to catch are in that ballpark, you can send, like right here is a cross-section of an electrical lead for a spinal cord stimulator. The idea is that you can send these signals all the way down here. This is the top part of the spinal cord that has a lot of your sensation, a lot of your nerves for sensation. And the idea is that you can just change the way these nerves kind of sense. So remember I mentioned that nerves have electrical energy? Well, you put a magnet over top of it, all of a sudden, it's not sending signals anymore. Or the signals it's sending are dramatically different. They're not the same. They're not pain. They may be just a sensation of touch or feel. But the other thing is that we know that certain frequencies of this electrical energy may change the way that receptors actually receive information. So there are certain receptors in your spinal cord that may not change the way they are shaped based on electrical energy. And so it makes all those pain signals coming in, they're just not continued on because the receptors that have received those signals, they're not going to respond. They're different. And then the last thing is we find that this is actually something that I do have evidence of, is that there are more of the feel-good hormones, okay, the endorphins in the spinal columns of patients that have stimulators implanted. So maybe it's just causing more release of the stuff that makes you feel good. And maybe that's what's leading to pain relief. Well, at any rate, this whole procedure is kind of drawn out. It works for certain patients better than others, but if you've ever gone through a spinal cord stimulator implant or a trial procedure, you know that there's a lot of things that kind of have to happen or line up. Some of the things that we make patients do, or I ask patients to do, is to have a psychological evaluation. There are so many patients that suffer through chronic pain that are just miserable. And it's not uncommon to see patients with anxiety, because you're walking through life saying, stay away from my arm. You're guarding yourself. And you're always worried about what's going to happen next, what might flare up your pain. There are plenty of patients that are depressed too. Like, am I going to be like this forever? Is this the way my life's going to be? I can't do the things I used to do. This just isn't fun, isn't worth going on. And so there's patients that do have mood disorders that come along with a chronic pain condition, and this is completely understood. Some patients, though, need to have that treated before they go through anything additional, anything invasive for that matter, because it's really hard to get better if you don't treat that other part of your pain, and it truly is a part of it. The initial procedure to actually try even a stimulator out requires a trip to your pain doctor's office or an outpatient center where you can have these implanted. There are no incisions. And these things stay in place depending on your pain doctor, whoever implants them, for 5 to 10 days. That's usually how long I have my patients trial. And during that time, we look for a few things. We like to see patients able to do more, improve function, get around more, get out, do things that you weren't able to do previously. Like to see them have their pain scores at least cut in half. And then lastly, we like to see that they're able to reduce any narcotic medications that they're taking. And so, as long as you're meeting these criteria, then it's a matter of discussing whether or not one of these technologies might be a good option for you. The implant itself is a procedure that requires 2 small incisions. And you actually have a battery implanted, so you kind of become a bionic human being. And there are several restrictions post-op, and we do these and we put these in place because ultimately we want this type of therapy to be a long-term thing. I see, and I know that my colleagues always see, that spinal cord stimulation is a durable treatment, meaning that it's something that can stay in place for years and years and years and years and years, barring any problem with the device itself. The idea is this can give you a more durable treatment, it's something that you're not running back to the doctor every month for injections or nerve blocks, something that you're not going to get tolerance to, like medications. It's not going to give you any substantial side effects once you heal up from this sort of thing. The idea is you do these things post-op for a couple months, just to make sure that everything heals and nothing moves. Now, once you actually have one of these things, if you talk to anybody that's living with a stimulator, they can tell you, the benefits far outweigh some of these drawbacks. So you do have to recharge batteries, and depending on whatever type of system you have, it may be something you do every day for half an hour, it may be every week for that same amount of time, or even a couple hours. You're going to set off alarms at airports, and just about anywhere else you go. So sometimes if you actually set off alarms, you're going to have a card that actually says that you are bionic, and that's okay, and nobody should be afraid of you. One of the fun things about stimulation is that we find that over time, you may sense it a little bit different. It may be a little bit too strong over time. It may be a little bit too bothersome, or maybe it's because your CRPS, you may be feeling it a little more creeping up the leg or further up your arm. These things can be reprogrammed in the office, which is awesome because it doesn't require anything uncomfortable. No pokes, no needles, no incisions, nothing. You just sit down with either your doctor or one of our trusted representatives from the company to actually sit down and plug in some new information, try out a different program. And the cool thing is also with this is that software updates like your iPhone are coming out for these stimulators, and you're able to do more with them, which is so much fun. Now, there are certain restrictions. Probably shouldn't have one of these if you're an arc welder. If you work around very strong magnetized speakers or any sort of tag deactivators. These are in the manufacturer's list of restrictions. And MRIs. Now, everybody always asks about that because, I'm sure anybody that's been dealing with chronic pain has had an MRI or a dozen of them at some point in time. And you can receive MRIs depending on where your stimulator's at. And so that's actually getting even better as far as technology advancing. So we find that we're able to do these now with very, very small incisions compared to previously. We find that we have better surgical techniques. So one of the worst things that can happen when we implant these is an infection, and we're getting even better about preventing those. The equipment. So they make, when they originally came out, I showed you that one picture a long time ago. That thing had one contact on it, one way to provide stimulation. We have leads now that have 16 on them. So that's a pretty cool thing, because that usually means we can cover bigger areas of pain. The batteries are smaller than they used to be. The batteries last longer than they used to. The anchors that we have to prevent them from moving or migrating, they're even better. I know a lot of this is kind of technical, but it's stuff that gets me excited. And then the other thing is the understanding. I think that the programming is probably one of the biggest things right now. Understanding that there are different types of programming that work for different types of pains better. And we have even newer technology that allows for stimulating other areas, like the dorsal root ganglion, DRG stimulation, which is a big thing that has come out recently. And I think over the next few years, we're going to find that that is a really, really beneficial thing. So I think that spinal cord stimulation gives you pain relief without having to have the burden of being on medications that you're going to get tolerant to or have side effects over time. It's a durable treatment that can last, and I think it's going places. It really is. I think that in the future, there's going to be apps on all your phones. You're going to be able to control your own devices, which will be great. I think that they're going to be more specific when I think indications. So certain types of stimulation maybe work better for certain types of pain processes or pain diagnoses. And we're getting better. We're always interested in kind of pushing the envelopes to see what we can do as doctors, because if we think we can do it safely and it's potentially give somebody substantial relief that they haven't had, we're willing to try. So I'm no means a salesman. I'm here to answer questions. This is a technology that I do believe in. It works for a lot of people, but not everybody, and I realize that. So thank you for your attention. I really appreciate it. Thanks for having me again. All right, saw some hands up. Yeah.
Oh. And also...
Oh, she has a loud voice.
And also...
Okay.
This is on. Can you hear me now?
I can hear you.
Okay. So what diagnoses you use it for? And also, the last research I looked at this, I think was like a Cochrane review, was not very favorable for its use in CRPS, so if you can address the current research.
Yeah, absolutely. So there are several indications. Patients that do poorly after back surgery, what we call it failed back surgery syndrome. Couldn't come up with a better one. But failed back is one of the syndromes we use it for. Chronic radicular pain, or chronic pain that's from nerves being inflamed within the spine or entrapped within the spine, whether it's in the neck or the low back. Patients that have history of intercostal neuralgia, so patients that have had previous outbreaks of shingles that still have pain afterwards, it works well for. Patients that have prior chest surgery, we call it post-thoracotomy pain syndrome, or even post-mastectomy pain syndrome. Women that have had, or even men that have had prior breast surgery due to cancer. I'm trying to think of some of my other ones that are common. Peripheral neuropathy is another way, or another reason that we use it. CRPS is one of the reasons it can be more challenging. I agree with that. And I think that the evidence supports certain diagnoses more than others. And I think that depending on the type of literature that you pull from, the Cochrane database reviews do a nice job of pulling together a lot of information. But the problem with that is that you get some, for lack of a better term, heterogeneous kind of information. One population may not be the same as the other one, so we may not be comparing apples to apples when we put them all together. I mean, from the Cochrane database review, maybe pulling a whole bunch of different types of studies into one to try to come to a very firm conclusion, and you're just not able to. But I think if you look at individual studies and studies that are pooled for specific disease states, like CRPS or even like failed back, the results are favorable overall. Thank you. Oh my goodness, okay. Got any more on this side of the room before you walk all the way over here? There's a young lady right here. Yeah.
So so you have the unit inside you, like say you have osteoarthritis and then you have like back pain.
Mm-hmm.
Do you use the same unit for all of that, or do you have to put in different units?
Depending on the anatomic area that we're trying to actually cover, we use that term cover, but that we're trying to actually capture those areas of pain. If it's back, anything in your low back down to your legs, generally one unit or one device should be able to cover that. And like I said, what's that?
So including like the hips or?
Yep,
Okay.
right behind you.
Can you just talk about the use of the DRG stimulator for CRPS?
Yeah. So DRG is a newer technology. It was originally introduced in Europe, and it's now available in the United States. There are very few centers in the States that actually do DRG stimulation. And so the doctors that are doing them are still getting their feet wet with them. One of my partners at Rush has actually done some of these implants. I have not personally done them, but the early results are fairly encouraging, meaning that I've seen, and this is my take on it, is that my partner's patients that have done historically poorly with everything else that has been tried, patients that have been on medications their entire life, patients that have even had drug pumps implanted for their pain that are still not so happy. They're actually getting some relief with this. And so that speaks volumes to me, that patients that have failed everything else are finally starting to get something. So I think that over time, I think the evidence will support that. All right. I think we had some questions over here in front.
We have a question from somebody in live streaming. Her name is Chelsea. She wrote in, I'm allergic to many metals, including nickel and gold, and I've also reacted to silicone. Is this a concern for the stimulation implants?
It is. And I've actually had some of my patients, before any sort of stimulator implant, if they have a number of allergies, especially to metal and other common medical materials like silicone, like medical grade silicone, what I've done is the device manufacturers have allergy testing kits. And I've sent the patient to an allergist and actually had them tested so that we don't go through this whole process and then in the end have an allergic reaction and have to go through yet another surgery to actually take a device out. But that's a good question. It's a very good question. Yes? Oh, she has the microphone. I think she's next.
Hi, Dr. Young. My question relates to spinal cord stimulation for CRPS in the lower extremity. Is it more difficult when you're working down to the ankle and trying to keep the leads in place and working? And then the other question I had was battery life.
Mm-hmm.
You know, I know a lot just from the heart world, not personally, but that, you know, things like defibrillators and, you know, similar in that they have batteries, they have leads, they can all go wrong and need replacement. Is it similar with spinal cord stim?
So the first part of your question was regarding coverage of the leg, the foot, the ankle. We find that covering the foot and ankle can be more difficult. You want to position leads in those cases towards where the spinal cord ends, and that's a little bit different than everybody. And trying to actually cover the foot and ankle can require a little bit of finesse, sometimes a little creativity. You may need to implant the leads a little bit different as well. In some cases, I've seen, unfortunately, patients that can't get coverage with traditional approaches where we put the leads up the spine. And instead what we've done is, instead of going up, we go down to stimulate those nerves directly. It was more of a rudimentary form of DRG, if you will. And now that we have DRG, I see that becoming much less of an issue. And then the second part of your question was regarding batteries. And so these rechargeable batteries are good. They offer you the option of being able to continuously recharge your battery. You live with a smaller battery because the non-rechargeable ones are much larger. But the rechargeable ones eventually will start to hold a charge less and less over time. They tend to last between 5 and 7 years is what I tell patients. And it all depends on how much you're actually using it. So I think the more you use it, the more that it actually discharges completely, or you use up all your juice. I think that's when you start to run into problems. If you use all your juice and it's happening on a regular basis, then you're going to have a little bit of a shorter lifespan on your battery. Replacing batteries is pretty easy. It's a same-day procedure in and out of an operating room. But it requires an incision. We go through that old incision right there that you had. Yeah.
I have 2 spinal cord stimulators, and my question is
You might be more of an expert than I am.
Is it ever going to be possible that we can somehow connect our spinal cord stimulators with our smartphones so we can change the settings without having to carry an extra device with us?
That's a great question.
And you have 5 minutes left.
Okay.
Sorry.
All right, that's fine. That's fine. Thank you. Thank you. So, one question and one threat. Okay. So I think that over time, we should be able to develop technology that will allow you to do that. I think the tricky thing is you've seen all these cars that are out there now that have remote starts. You can start them from your phone with apps, and how people are getting their phones started by other people. The whole system is getting hijacked. I think the concern is that if you had that with your medical device, that somebody would be able to hijack your stimulator system.
Never mind, I don't want to hear
Oh, no. I think that's the concern right now. And so I don't think it's going to come out for a while, but I think as soon as we have a way to uniquely encode your stimulator or a battery that will allow you to use it from one device, or having, we got fingerprint technology on our phones now. I think it might be just a matter of time for some research and development from one of these companies to develop a safe way so that you and only you could control your stimulator. But I think it's something that's out there. I think that's real. Absolutely.
That would be awesome.
Yeah, you don't have to carry on then 2 things that look like phones. Just one that actually is a phone.
Maybe through our cell phones too, then we wouldn't have to carry our charger.
Oh, then you'd be draining your phone battery all the time. Oh. Anything else? I see a couple hands back there.
I have 2 as well, and I'm on the support group, and an individual on there had made a comment that they're coming out with a new programmer that can actually program both stimulators. Is that correct?
2 batteries speaking to each other, I'm not aware of anything yet.
Okay, so I still have to carry 2 suitcases around.
Sorry.
Thank you.
You're welcome. I think eventually what we're going to probably see is a battery that can accommodate multiple leads. So maybe leads from the neck and leads from the low back could all connect to one. There is a system out there right now that can accommodate that. But if you have systems that are implanted on two separate times, depending on the number of contacts you have, yes and no, it can work. But right now, programming to have 2 of them, 2 independent ones talk together, that's not out there to my knowledge.
Hi. I had an actual consult to get a spinal cord stimulator. I was all excited. They were talking about the halo. And I get there, and apparently Medicare has changed its coverage. And if you were on Social Security disability, you were able to get a spinal cord stimulator covered. It was even pre-authed, but once I got there, the guidelines had changed. I don't know if that's happened to anybody else or they've had stumbling blocks with coverage if you're on Social Security disability. Do you know anything about that? And if things have changed or if people are getting this covered?
That's a tricky subject. I know that my patients that I offer stimulation to, they generally they have Medicare or some type of insurance plan. The ones that, because of the setting that I practice in, I know that they do permanent implants and stimulator trials for patients. Thank you. I was just notified my time's up. But there are facilities that actually do, regardless of your type of insurance. Okay? So
Thank you.
there are places. Okay? Thank you very much. I appreciate all your attention. Have a great day.